Good afternoon, everyone, and thank you for joining us today for overcoming the challenges of providing medical care for the underserved in urban areas. We're excited to hear from our speakers, Tom Foley and Dr. Ira Kirschenbaum, to offer their insights and expertise for today's webinar, as well as an introduction from the CEO of ATA, Ann Mon Johnson.
Thank you, Bridget, and good afternoon or good morning, everyone. I'm Ann Mon Johnson, CEO of the ATA, and I'm here to welcome you to today's ATA webinar. One of the core public policy objectives and priorities for the ATA is helping to identify opportunities to use technology and telehealth in particular to reduce inequities in healthcare and improve access to care for millions of Americans who are underserved. We are also very delighted to support and recognize the work of those involved in those efforts, which is why today's session is so important to us. And we're so delighted to have Ira and Tom, Ira Kirschenbaum from BronxCare Health System and Tom Foley from AMD Global Telemed present today. Our hope is that their work can serve as a template, spur conversation, best practices for other communities facing similar cultural, demographic, and structural complexities and disparities. So with that, let me quickly introduce Tom Foley, who has over 30 years of experience in information technology. He has a history of leading transformative initiatives in and outside of healthcare. He's Vice President of Growth at AMD Telemedicine. But he's also a thought leader. He's writing and speaking with a particular focus on reimagining the delivery of care. And with that, hosts the Healthcare Now radio program, The Virtual Shift, Reimagining the Delivery of Care. He's joined today by Ira Kirschenbaum. Dr. Kirschenbaum is currently the chairman of Orthopaedic Surgery and clinical lead for telehealth for the BronxCare Health System, servicing a 955-bed hospital system that has over nearly 1.2 million outpatient clinic visits a year. He is also the editor-in-chief of the Journal of Orthopedic Experience and Innovation and a frequent author and lecturer of topics related to health information and management. With that, let me welcome both of you and turn it over to Tom. Thank you.
Thank you, Ann. Appreciate that. And welcome, Ira. Look forward to this conversation. Before we get started in the conversation, I believe, Carrie, you have a poll question that you want to post here, correct?
Yes. So the first question, where is your organization on the continuum? We've got virtual interaction, remote examination with device integration, remote screening and monitoring, manage consumer wellness journey, or maximize population wellness. Please enter your answer now. We'll wait a few minutes. It's actually a steady race. Watching the numbers, I'll post them in a minute. About half people have voted, so if you could please just put in your vote. Okay, I'm going to go ahead and end the poll and share the results here. We've got the winner is the virtual interaction at 48%. But if you look at the numbers here, the others aren't that far behind. We've got remote examination, device integration at 27%, maximize population wellness at 25%, remote screening and monitoring 23%, and then manage consumer wellness. Now you could pick, I believe you can pick more than one, obviously, on this, but obviously the higher, most of the percentage, half the people picked virtual interaction.
Awesome. Very good. I appreciate that poll and your insights. Before we talk specifically about what's going on at BronxCare, I thought, Ira, we would start off by just talking about telehealth in general. You know, obviously this market has truly exploded due to the unfortunate scenario with COVID-19. And as I call it, I break it down into 3 and maybe 4 chunks. And that is that first, they had to do, health systems every place had to do something. So it was, and obviously CMS relaxed the rules and said, you know, take HIPAA off the table. And, you know, if you need to use a non-HIPAA compliant platform to have a video encounter, then do so. So that was really the kind of the response mode. Give me something, because I can't see my patients in my brick and mortar facility, but let me get something and adopt a video type of platform to get started. And then there, as I see it, we are in the recovery phase and moving to reimagining the delivery of care, because the response told us that both the patients, the consumers, and the providers like the use of telehealth. Not that it is the end all be all relative to the delivery of care, but it certainly has now created this adjunct um, capability of providing the delivery of care. Any thoughts that you want to give on that, Ira, before we go to the next slide?
I agree with you that we're probably a little further into the reimagine part, because people are realizing, as we hopefully are coming out of COVID a bit, that there are new, exciting, and innovative ways for us to use telehealth that are probably specific to each institution. So I think what we're going to find out, there's going to be a lot of benchmarking of novel ideas on how to use it for your specific purposes. It's the beginning. It was really just the start of, we just need to catch patients who can't come in. But now we're realizing the application to enhance things that we're already have been doing for years.
Yeah. Awesome. So let me just move on in the conversation. So this is the kind of the replica of any community. It's not just the hospital system. It's not just the clinic. It's where does the consumers come from, and or said differently, what consumers does the healthcare system that I always look at as being core to a community, who do they serve? So each one of these are different settings and ultimately unique in how you reach out to them and engage them. And ultimately, so certainly with a video only platform, you can have what we're doing today. And just for clarity, just because you're a doctor and I'm a consumer, we are not in a telehealth session today. So, but the point is that as you look at reimagining care, it's about how you reimagine care across your community. And the Bronx is really doing a phenomenal job. And how they are approaching that. Any thoughts on just a high level 50,000-foot model view of your thoughts on this?
Well, we represent an institution that's not dissimilar to a number of communities in this country. I like to think 10 to 15% of healthcare is similar to us, whether it's Cook County in Illinois or LA County in Los Angeles or similar hospitals. We pretty much hit every one of those examples in your circle. So, we are an FQHC. We have contracts with corrections, schools, employers, huge ambulatory. We have 140,000 emergency room visits a year. So EMS, the whole thing. I mean, we represent an opportunity to solve a number of significant problems that we've had with telehealth, not with telehealth, but using telehealth to solve these problems.
Interesting. So, as we look at telehealth, as I've alluded to here, it's not really just about the video. And just for clarity, a video only implementation of telehealth has its value and has its place. But when you look at the continuum of care and the outreach to the different communities and how you manage different chronic conditions and things of that nature, there's obviously other elements that are key here. So in the upper right-hand corner, the unique support of the settings of care, we've kind of outlined that in the previous slide. But what's also important is, how do I I can have an encounter, and that encounter with a patient using telehealth in the lower left-hand corner has a number of different virtual modalities. It's not just about having a video, it's about how you engage in an async manner, a synchronous manner, and potentially, as I always say, if it was important to measure vitals when you were in the brick and mortar facility, it's equally vital to actually collect that same information in a virtual setting. Not every virtual setting, but the capability needs to be there. So integrating different medical devices into that model is critical. And then obviously that single longitudinal view of the patient's record within that health system. Therefore, any data captured within a virtual setting needs to be captured into that EHR. And when I say data, I'm really talking about, how do I stream video from an otoscope, ears, nose, and throat? How do I stream data from my pulse ox or my blood pressure cuff? And audio. You put a stethoscope up to my chest or my back. How does that audio get to the other side of the internet where the doctor may reside? So that's very important to capture those images, that data, that audio, and store that appropriately for again recording of that record. Doctor, any thoughts on that? The importance of that larger view of telehealth beyond video?
Yeah, every time I look at a slide like this, which is extraordinarily accurate, I think of the overlay is actually the purpose of doing telehealth now is to manage the continuum of care. You know, we often think of single transactions. I see the patient, got their blood pressure today, but that's not the power of this. We, in a value-based world now, or an increasingly value-based world, are going to be managing not only procedural continuum of care, but also ICD, or diagnostic related continuum of care. So we're going to be looking at the care of a diabetic over an entire year, okay, over their lifetime. And I can't really imagine doing it as effectively without this layout that you have so nicely put together. But people have to really understand, without looking at the concept of continuum of care, of the entire diagnosis or the entire procedural continuum of care, they will probably miss the full power of telehealth.
So, well, that's interesting. So the idea that how do I manage a person with diabetes, so it's oftentimes if I use the phraseology of the average Medicare patient with 5 chronic conditions sees 9 different doctors and is only in front of the doctor 15 hours in a given year. The question is, what happens in the other 8,745 hours? That's really where care is most concerning. So how do you do that when you talk about devices and managing a person with diabetes? How do you look to manage that in the context of how do you capture that data in that 8,745 hours?
Well, first of all, it's interesting. I mean, usually the way I manage diabetes is ask the diabetologist to do it because I'm an orthopedic surgeon. So that
Okay,
gets me off the
fair
hook.
enough.
That gets me off the hook rapidly. But whether it's diabetes or managing the continuum of low back pain, or whether it's essential hypertension, you have to look at the many events. For example, compliance with taking their medication. You may see a diabetic every month in the beginning and maybe every 3 months as a check, but for sure, there are so many times that remote patient monitoring can give you alerts of their glucose levels and controls. And we of course have to set up systems to respond to remote patient monitoring. In fact, I like to call remote patient monitoring remote patient data collection because we're not always real-time monitoring it. But the reality of this is very, very clear to me that the in-between times are extremely inconvenient for the patient to take a bus or a car or whatever to the doctor's office, wait online and do things. So they opt to do nothing. And telehealth will, in my opinion, be a path of least resistance to access the provider's office. It'll probably force a change in the way the provider office is structured. You know, there may be more mid-levels, there may be more people answering phones, there may be outsourcing certain things. There's going to be a radical shift, I think, in who is working in a doctor's office now, okay? Because just like I say in physical therapy, you go to physical therapy 2 times a week for 6 weeks. That's 2 hours a week. There's a lot more hours in between. We've got to get you working on your joints and exercise. So in the same sense, those hours in between is exactly where errors and drop-offs in healthcare happen. You know, and it's a great opportunity to fill that gap.
Interesting. All right, let's move on in this conversation. Just to kind of, look at the full scope. We talked about the different elements, the modalities of care, medical devices, and things of that nature. Let's talk about different use cases and how you scale virtual care across the community. I look at it in 3 separate continuums, if you will, that are all integrated. You know, you could in today's world with the telehealth platforms that are available, move from an asynchronous encounter, meaning, hey, I can go into the virtual front door or send a secure message to my clinical team, and that might allow me to record my complaint, if you will. That ultimately allows them to respond. They could say, hey, I got it. I think you got a sore throat. Go I just sent a prescription, go to your local pharmacy to pick it up. No need to have a virtual encounter, if you will, or no need to have a video encounter, I should say. But the doctor could say, hey, let's schedule a time, or let's have an urgent engagement where we are now in a one-on-one virtual encounter. So that's what I would refer to as a low acuity encounter. The doctor and patient further talk, care plan is established, and they separate their ways. Moving forward, and when you talk about monitoring service, I absolutely agree with you, Dr. K, in that I look at monitoring services in 2 ways. One, I have a medical device in my home. It was issued to me by my provider, and I'm going to self-monitor. I want to know what my glucose level is on a day-to-day basis, or I want to know what my blood pressure is, or I want to know what my vitals are on a day-to-day basis. But I don't have any need, and that data could flow to the provider as a record, but there's expectations that there's no one truly monitoring it other than myself. And then you have what people often refer to as remote patient. And I should say monitoring services can come in a third form, in that a visiting nurse could come to the home and they are monitored in a, maybe using the devices that you already have, or maybe they're using the clinic, bringing the clinic with them, meaning a telehealth platform and medical devices, and doing that record recording as such. In any one of those scenarios, I could escalate this, in that if I was self-monitoring and I know my glucose level is off the charts, I want to create an urgent call, or maybe, and that's me, a patient, initiating the call with the provider. Maybe in a remote patient monitoring scenario, the provider realizes that they are that they need to talk to the patient, and hence the provider calls into the to the patient. And last but not least, the visiting nurse could say, hey, let's get a doctor on the line. There's some issues that need to be addressed. So we go from low acuity encounter to monitoring services. Then the high acuity encounter is I have a clinician slash patient on one side of the internet, and I have the provider or the clinician on the other side of the internet, and we're doing a full high acuity encounter. And that combination of a platform that can service all those different use cases is one that can allow a community to scale their virtual care services accordingly. Any thoughts on that?
Well, you and I have talked about this before. I know there's a tendency to think that we need to monitor these high acuity patients, and it is so important. But in preventive medical care, which could prevent a high acuity moment, we're going to get the biggest bang for our buck in the interface between the low acuity encounter and the monitoring service and high acuity encounter. You know, you can have an incredibly high acuity encounter just with a history and physical exam and looking at a wound or looking at someone's breathing pattern. I think it's very sexy to be brought into we have more devices to put on people. We have more remote patient monitoring. Sometimes the best patient monitor is, did you take your medicines today, Bob? No, I didn't. Well, now you're looking at me. You look pale. You know, those are the moments I think that we have to be careful of living in the green and purple area too much, because you could prevent patients from going there if you navigate the patient properly through what is to some people, but it's not actually this, the tedious navigation of their care in the blue area. And that is really important. Now, you may put a couple of limited devices to help out, you know what I mean?
Yes.
But you could also integrate with the pharmacy and know that they picked up their medicines. But, you know, I still always caution everyone not to be swayed in the pleasure of living in the green and the purple.
No, I agree, actually, and I'm going to reflect back on the poll that we took in the beginning of this session. You know, it looked like a majority of the attendees were in that low acuity encounter. They're doing video, and the point of this slide is to say that's probably where a majority of the care is going to happen. However, if you want to scale in a full breadth and depth of continuity of care, make sure that the platform that you're adopting has the ability to get into the blue, to the green and the purple, right? Yeah. So, and that's the point, is that you just don't adopt something and know that, geez, it's just video. I can't do anything else, right? It's about, yep, I could do video, I could do monitoring, and I could do high acuity encounter. The green and the purple are going to be a less percentage of usage. But at the end of the day, the platform that can do all three is going to best serve that community.
Yep, absolutely right. I agree.
And that's the scaling of one platform across the community. So with that said, the introduction of telehealth, tell us a little bit more specific about BronxCare Health System.
Well, BronxCare Health System, which originally, in 1890 was the Bronx Hospital, which merged in 1920 with the Lebanon Hospital. And in 1963, they merged to become Bronx Lebanon. We've expanded quite significantly. And approximately 4 years ago, we changed our name to more appropriately reflect what we do, which is take care of the health of an entire section of the Bronx. We are the only not-for-profit, non-governmental hospital in the South Bronx, the true South Bronx, was the Southwest Bronx. We have somewhere between 850 and 950 beds, depending upon how we flex things. Quite a lot of employees. We have an integrated system of where all the physicians are employed, and there are over 500 physicians and providers, including mid-levels, nurse practitioners, nurse navigators, and a variety of others. We have 2 campuses. The main campus is where the hospital is and our major outpatient facility. And then we have a separate campus where it's primarily the psychiatric and chemical dependency programs, which are huge advocates of telehealth, of course. Our ERs, I told you, sees 141,000 visits, and we're not a level 1 trauma center. So these are walk-ins, people coming with ambulances. We are a force of health to this community. We like to call ourselves doctors to the community. Our community happens to be the size of the city of Cleveland, just our community, but we take the concept that we are a community hospital in an urban setting very, very, very seriously.
So when you look at BronxCare and its and the community it serves, you know, from a payer perspective, I would say that there's probably 4 tiers. There's self-pay, there's Medicaid, there's Medicare, and then there's commercial care, commercial plans. Where would you say a majority of your community members sit in the context of types of services that payment services that they use?
Sure.
Sorry.
In a general sense, first of all, 95% of our patients have some form of insurance. All right, 95%. 5%, which in a clinic population of 1.2 million visits is even 5% is quite a bit, are self-pay or what we call charity care. A vast majority, maybe about 80%, are managed Medicaid or managed Medicare, okay? Which is a form of commercial insurance, but it's really managed Medicaid, managed Medicare. Then we have straight Medicaid, maybe about 10% of that, pure Medicaid, because many have gone into the managed care Medicaid programs. And another 5 to 10%, 5% are Medicare, all right? The managed Medicaid and managed Medicare represent an extraordinary volume and majority of our patients.
Does that present any unique challenges? So, you know, the BronxCare is, as I look at it, the last line of defense for care delivery to the community. But at the same time, you're working in a geography that is very challenged in the context of the ability to pay for care and to receive. I guess I want to use the quality of care. I'm not saying that. So there's always a balance between access, quality, and cost.
Yeah, sure.
Can you talk a little bit about that?
Well, you know, I'll first start with a slight correction. While we are a safety net hospital, for sure, we don't think of ourselves as the last resort for care. We think of ourselves as the first resort of care and the first choice for this community. The people here do have choices. They can go to a city hospital. They can, this is New York. I mean, you can go to Manhattan somewhere. So we like to feel where and I say this very clearly, that we are a hospital of choice for this community, and we want to remain that. And to do that, it starts with quality. All right. And we have certainly in the last 15 years, under the leadership of the hospital, looked at many programs that I could look back even 15 years ago that are exponentially better year after year. So quality always wins, and quality starts first, okay? The cost is handled because we accept all the managed Medicaid plans of the patients in our community. There are a few that slip through, we don't accept, but in general terms, it's a rare day where a patient comes in and we don't accept their plans. And that's usually because some of the plans have what are called narrow networks. Like we may be par with Plan X, but they may have decided to do a narrow network with another hospital, so they're not par with us. But we work very hard at matching our contracts with managed care payers with the community to improve the access. And you know, to some extent, you know, when I cut my teeth my first 5 years at Kaiser Permanente, and there used to be a line, you really can't have incredible access, incredible quality, and super low cost. You have to find the balance. And one of the, we just have a sheer huge number of patients in the Bronx. And we probably can't service all of them, you know, next Tuesday, right? So we have to work very hard at proper triage and making sure the right people get to the right doctor at the right time. And that is a very big challenge. And patients have access problems even physically getting to the hospital. Imagine someone living on a 5th floor walk-up with end-stage knee pain, knee arthritis, that has to take 2 buses to get here. That alone is just a huge challenge.
Yeah. And talking about challenges and barriers and issues, tell us a little bit about how the integration of a virtual care delivery model is taking place within the BronxCare Health System.
Yeah, sure. I mean, we started our journey about about 2 years ago in investigating, about a year before before a start of the pandemic, and we have spent the last year drilling down more and more in pilot study after pilot study about how are we going to, what are the nature of the barriers and how we're going to overcome them. Okay, and that consumes our telehealth program. Because if you can't get on or you can't interact as a patient, it doesn't matter what program you have. It doesn't matter what program you signed up to. And it doesn't matter what features they have. The best program, or to use an old line from Apple, the best computer is the one people use. You know, the best program is one that is actually in use. So we've gone, and I know, Tom, you came and visited us and you saw us in action, you know, working with patients on doing telehealth in front of them and analyzing where they were having problems hooking in. So we've done a few hundred patients already with them being in the room with us and acting like they were at home, but we weren't prompting them. We were trying to see where the problems were. So I think, first of all, people underestimate the limited bandwidth issue. You know, not everybody in the country has super gig, FiOS, Optimum, Spectrum, mobile, 200 megabytes per millisecond speed. You know, we're dealing with cell phone speed, roaming. So limited bandwidth in our community is a problem. Limited data plans as far as how many bytes of data you get per month is a big issue for patients. Smartphones are part of our lives. So people do want to be on Facebook appropriately, get news, get feeds, and live their lives. A half-hour telehealth visit chews up a lot of data plans. We have to be careful about that. There's a concept which I call phone literacy, which actually is not unique to an underserved population. We can get this in an elderly population in any community. We found out, I know you saw this in action, there was quite a few patients when they had to type in their name, didn't know they have to click the box that says type in the name and that a keyboard would come up. They just didn't know that. And for techies, we're saying, wow, I didn't know people wouldn't know that. But we're learning a lot of things. So now we have we have like reminders. Click in the box and a keyboard will pop up. You know,
Yes.
it's almost like the reminders when you go to the bathroom, you know, put the toilet seat down and clean up after you, you know, like at workplaces, you know. Sheer volume of patients is always an issue because we are in a multi-tiered, diverse community, diverse socially, diverse racially, diverse financially, and we have to come up with a plan that, in a sort of like a linear regression kind of way, what is the best line that fits all the data points? And we're realizing we may not go that way. We may have a lot of departments and a lot of different programs for each of these subgroups that we define. So you need to understand the patients on their terms, not force them to go into your box, but you have to go into their box and say, how are they living? And if I was them and I was there, what would I need to get to my doctor? All right. It's not a question of training patients on phone literacy. It's a question of changing your software to compensate for the phone literacy. All right.
Absolutely agree.
And the other thing we really found out that departments need specific plans. And one of the things I lecture to all the departments here is that you have to use telehealth to solve specific problems that you have. It's not just about getting the patient who can't come in because of COVID or who can't come in that day. That's low level. Each department has unique, each division, department, whether it's cardiology, GI, orthopedics, neurosurgery, have different problems they have. And I like to say we need to have a problem-focused telehealth solution. Because if you're not solving a problem, you're just getting a person on the phone. I could have called them. Yeah. But we have a number of initiatives, which I know we have another slide on, that are trying to solve problems. And the other issue we face, big issue, is the cost of remote patient monitoring devices. To some people in the country, an $80 blood pressure machine is a bargain. To someone below the poverty line, that's a hardship. And we know that. And that's a real thing. Well, we just got a grant to do blood pressure monitoring at-risk patients. And the grant included us giving out to, I think, approximately 10,000 patients over a 3-year period, remote blood pressure monitoring machines. All right. We always find ways to jump past the costs because we don't want cost to be a barrier to delivering the care. So these are the major ones. Yeah.
Yeah, and even so, when you talk about devices in the home and how do you monitor hypertension, and you have to even look at the device. You know, the one word that always comes to mind when I think about the home is simplicity.
Right.
So, you know, and I think about my 82-year-old mother. Can she put the blood pressure cuff on? Can you get an accurate reading based on how, you know, everything was set up? And can I get Bluetooth? And, you know, there's just a lot of quote unquote complications. So I'm very much aware of your program there, and making sure, and I know you've done an excellent job in making sure that there's simplicity in the program. To maximize success. That all said, when you talk about bandwidth, data plans, smartphones, blood pressure cuffs, do you think technology in and of itself, and you know, even telehealth and generically, is a barrier because of the lack of access to technology?
Well, there's two ways to look at it. Certainly, there's a division in people who have access to technology and people who don't. And those who have access to technology easier probably have a deeper knowledge of how to use the technology. So if you just got in 2021 your very first computer at age 32, you're not really understanding TikTok, Snapchat, LinkedIn. You haven't been with the program for a long time. Okay, so it's also an age-related thing. What age are you when you get your technology, and how long have you been playing with your technology, and who has been teaching you? So I am just personally a very big believer in public bandwidth. I mean, I think public access to broadband is critical now. I mean, it's critical just to keep you as an informed citizen. But in healthcare, we take access to an equal level of quality very seriously at BronxCare, and we work extraordinarily hard at overcoming the bandwidth and the data plan issue, because technology is here, and it's sort of like saying for example, we have the technology now to cure hepatitis C. It just costs a lot of money. Now, so my answer sometimes is, if money is your only problem, you really don't have a problem. Why? Because all we got to do is pay that money and your hep C is done. Now, I know that sounds foolish because who's going to pay, and there's all kinds of arguments, but the reality is, if the hardest part with hepatitis C, for example, was finding the solution, getting the cure, and some companies did that. Now the next thing is to pay for it. That should be easier than finding the invention. So in the same sense, if some very brilliant people have created the internet and created technology and created these telehealth programs, that was hard. That was hard work. But it shouldn't go away for the issue of accessibility. Technology that's not accessible, if you have bandwidth in the woods and nobody's around to hear it, do you really have bandwidth? It's like, yes, you do have bandwidth. You just have to. So I really believe technology for all is a very powerful policy point that needs to be taken up.
Absolutely agree. So we have 15 minutes left. I think we have 2 slides before we get to Q&A. So there are some specific initiatives, very exciting initiatives actually, that you're taking up there at the BronxCare Health System. Can you spend a couple of minutes to outline each one of these?
Yes, there was a question that someone asked about nurse navigators in telehealth, and I'm going to integrate that answer to that question in there. Okay, so these are just orthopedic only. This is an example of departmental solutions. The internal medicine department has another set of solutions. Family medicine has another set. So first of all, we were having a problem with cancellations in this community, probably about 3 times the number of non-underserved, percentage-wise, non-underserved communities for surgery, preoperative surgery. So we started with a nurse, mid-level navigator, with telehealth preoperative education visits to be able to take them through the whole continuum of care, what the walker looks like, what things looks like, demonstrations. And we're finding already a decrease in cancellations because of that. Again, problem, telehealth, hopefully solved. Everyone is very concerned about post-operative or post-discharge emergency room revisits or readmissions. So we started a very aggressive discharge clinic, telehealth discharge clinic. Now, in the old days, it would be the surgeon or the internist. When you got discharged from the home, you get a call that night with a simple question: how are you doing? But now with hospitalists and who's discharging and does the PCP know, having a dedicated group to do a telehealth clinic, discharge clinic, is going to decrease post-operative and post-discharge unnecessary emergency visits and readmissions, and maybe increase the necessary ones early to prevent complications. A simple one, which we started also, was we give injections in our clinic, and then we say, come back in 3 months. And one of my lines is, how do you know the injection didn't wear off in 2 weeks or 4 weeks or 8 weeks? And so the patient comes in 3 months later and says, I say, how long did the injection last for you? 3 weeks. So they've been 9 weeks in pain. Makes no sense. So we started a program specifically in our injection clinic that at 2 weeks, 4 weeks, and 8 weeks, they get a quick telehealth call. How you doing? How's the knee moving? Let me see you walk. And if people say it wore off, we bring them back earlier for the next level of intervention. There are 5 of them. The next slide is the 5th one. We work on clinic no-shows. Everyone who happen to have a no-show rate, clinics, we know this, have no-show rates. And I think in underserved communities, the no-show rate may be a little higher. I'm not sure about the statistics about that. But starting about 2 or 3 o'clock, and for example, in my clinic, the office manager and the registrar get all the no-shows registered for telehealth at the end of my day, and we do a telehealth visit to hook in with the no-shows. These 4 alone are problem-oriented solutions, all right? And the most exciting, I think, is the next slide, I think. So we are building out with AMD's help, of course, a virtual urgent care concept, which I think it's about time we had that, where someone could come into a virtual environment, sort of an avatar kind of environment. While they're waiting, they can get all kinds of information about the disease, the providers, what's going on. And we're envisioning a situation where on our website of our institution, for example, there will be a button, virtual urgent care. And then, for example, we haven't figured out the details yet because we're building it as we speak, but we have 18 to 20 emergency room doctors in the ER at any given moment. So 3 of them could hold a smartphone, and as soon as someone comes into virtual urgent care, they could right off the bat start a virtual visit. Think of all the people who have infirmities who can't even get to the ER and are calling 911 when in reality, they may not need 911 to get there. They may need advice. They may need the advice to call 911. So we're very excited about this environment, which has already been programmed. We just now have to program the front end a little bit and integrate it. And so I think something like this truly increases access. Urgent cares are popping up all over the place, but with people who have problems with transportation and 2 buses and train, virtual urgent care is a home run.
Yeah, I agree. Awesome stuff. Awesome stuff. So with that, I believe, Carrie, there are 2 additional poll questions that we have to ask.
Yes, I believe you already addressed the one about the navigator. So here's another one. Relating to truly mobile devices for preventative care, what capabilities exist with a platform to interface with OTC patient-friendly devices over the counter?
I lost track. Are we doing the poll questions, or are you asking questions from the Q&A?
Oh, sorry, that was a Q&A.
If you could just repeat the question since we're on it. I'm
Sure.
sorry.
Relating to truly mobile devices for preventative care, what capabilities exist with the platform to interface with over-the-counter patient-friendly devices?
Over the counter, I would imagine when you say over the counter, you're talking about non-FDA approved devices. So, at the end of the day, any device can actually be integrated, whether it be an Apple Watch or any other device. So we don't normally focus on consumer devices, because we typically focus on the clinical care, and therefore accuracy of data is important. So while we can do it, we choose not to focus on that at the current time. Again, considering the devices that we're focused on are about greater clinical accuracy and moving it forward that way.
I think this one's for you, Dr. Kirschenbaum. Does your institution provide telehealth cardiac rehabilitation in the patient home?
Well, that answer is very interesting because the answer is no, but soon yes. No, because we have a lot of basics programs to get done, and we just started integrating physical therapy in a virtual way, and that is a new project just started recently. Now, physical therapy isn't specifically cardiac rehab, but cardiac rehab is on that list of post-discharge services that can benefit better in a telehealth environment than in a live environment. And we see a high volume of cardiac patients. We don't do cardiac surgery here, but we have a large number of myocardial infarctions, and so cardiac rehab is, we just had a meeting about this a couple of weeks ago, is we will roll that out rapidly once we get to it. I don't believe it's going to be hard. We're actually spending more time perfecting the rehabilitation people, integrating with the telehealth solution optimally, and also deciding if there are, in each specialty, are there remote patient monitoring devices that can help or not? So we're going to do the ones that you don't need the remote patient monitoring first, and then the ones you need to monitor second. Because as I said, in an underserved community, access to a product that costs money is at times a problem. And we often, in various situations, we supply it as part of the discharge with the patient, certain things, whether it's, I'll see a patient in a clinic and we buy pulleys and other rehab devices that we just give to the patients. And it's just easier than having them go online because they may not be able to go online. So cardiac rehab is high on our target list, okay?
Okay, great. Before we move on, we do have some more questions, but I just wanted to put up that we have a couple more polls we wanted to add in here. Okay, so which level of virtual care engagement does your organization plan to offer in the next 12 months? The low acuity, asynchronous and/or video only encounters, monitoring services, or high acuity, meaning device integration so that you can provide remote clinical examinations? High acuity is winning. I usually like to wait till at least we have 50% votes, so just give it a little bit more. Okay, I think it's kind of stalled out a little bit, so I'll post the results here. We do have, so high acuity is at 55%, and low acuity, we have 35%, and monitoring services are at 23%.
Awesome.
Just share those results real quick.
Interesting.
And then we have one more poll question before we move on to the rest of the Q&A. So how has COVID impacted your organization's investments targeted at scaling to a virtual care delivery model aside from video services, significantly or minimally? Okay, we had a 76% have said significantly and 24% minimally. Okay, so go back to do you want to comment on that, Tom, before I move on?
No, just a very interesting findings. It's always interesting to hear what the listeners are and participants are, what their challenges are on a financial front and ultimately what they're looking to do from a strategic front. So very good insights. I appreciate it.
Okay, we have, I know we're almost at 2 o'clock here, so we'll just cover the last question if we can. And I know, Dr. Kirschenbaum, this is for you. Our telehealth company has exponential growth in adult care, more than 4,000 visits a day. However, pediatrics is struggling. Are you also seeing a much lower uptake of pediatric telehealth visits? And if so, thoughts on why?
Yeah, I think first of all, pediatrics here is pulsing only about 25% less than adult. But I anticipate when we start doing the disease management programs, it's going to fall behind because of the sheer volume of people with chronic diseases that are going to be managed with telehealth. Children, of course, have issues of managing asthma, managing juvenile diabetes, but there's no way the raw numbers of managing a continuum of care, those diseases exist more in the adult population. So I don't think it's an issue of the pediatricians or the families. Not only was I the club president, I also was a customer. I treat kids and I have kids. And I know if my kids were ill, I think I'm rushing them to the pediatrician's office. And I think that culture is not going to change for a while adults is different. But I think it has to do with probably management of diseases that are more chronic. There are just less of them in pediatrics. And that would be my somewhat educated guess on that.
Okay, great. Well, that looks like we're at 2 o'clock. So Tom, I'll just hand it over to you to close it out.
Awesome. I appreciate everybody's participation. Dr. Kirschenbaum, always a pleasure to speak with you. You're very insightful. You're doing some great things. You and the BronxCare Health System are doing some great things in the telehealth space. I look forward to working with you more in the future as we go. So thanks again for your time and your insights. And again, thanks again to the attendees. Have a great day.